So today's class is going to be on suction loss in smile. What is the pathophysiology of a suction loss in smile? Basically, smile has been known to have a soft docking. It works on the principle of accurvation rather than applanation, and the cornea is not forced into a deformed planar non-physiological shape. Basically, the low pressure suction cone applies only approximately 35 mmHg of pressure and is therefore associated with longer suction times and hence predisposes to intraoperative suction loss. It has been known that low suction pressure may reduce the risk of postoperative retinal detachment and also it lessens the endothelial cell damage. So what are the predisposing factors for having the suction loss in smile? First, most important is an inexperienced surgeon. Many studies have repeatedly shown that there is a steep learning curve in smile and the suction loss and the rates of suction loss are higher when you're starting out and they tend to get significantly lesser when you start practicing frequently. Other factors include a tight speculum, which is going to cause the patient discomfort, pain, and also going to tighten the orbital anatomy. Improper application of the surgical drape, difficult orbital anatomy like prominent brows, deep-seated eyes, and a prominent nose, loose conjunctival tissue, anxious and uncooperative patients, which tend to move a lot, Bell's reflex in the patient because of the speculum, and sudden head or eye movements. So in the beginning, we are going to just have an overview of the discussion, and then later I'm going to take you through the papers that have published and the points that they have put forth. So how do we prevent suction loss in smile? Most important thing is preoperative counseling, and it is essential to calm an anxious patient and to explain what is expected from the patient and what they can expect during the surgery in terms of their visual outcome. Machine calibration, vacuum tubings, and the size of the patient interface should be checked preoperatively. Proper positioning of the patient head should be ensured, and the head may be slightly tilted in order to avoid interference by a prominent nasal bridge. The speculum and the drape should be properly applied and make sure that it does not exert any undue traction onto the tissues. The cornea should neither be too moist nor too dry. Loose conjunctiva should be always swept away from the cornea by a Merocell sponge, and the conjunctival fornices should be dry with no fluid collection. So if you have an intraoperative suction loss, what do we do? The managements and outcome depend on the stage at which suction loss occurs. So basically, we have to identify the underlying cause and correct it and identify at which stage the suction loss has occurred. If the suction loss occurs.
So Pranav, can you hold it here?
Yes, sir.
So you've spoken about the preoperative things, and yes, you also spoken a little bit about intraoperative, what all we should do to prevent a suction loss, right? But I think what is the flow of the talk now? After this, what all are you going to tell us?
So, sir, I'm going to take you through the steps of when the suction loss occurs, what to do, and then I'm
Okay,
going
so
to
अभी ना
discuss.
वो वाला part actually ना complete नहीं हुआ. There were what to do to prevent a suction loss is not yet fully covered.
Yes, sir, that will get covered
Can
as we
you tell
start
me what
discussing the papers.
papers?
Yes,
अच्छा, literature.
literature. Yes.
Chalo,
So
even
the
before we go on to the literature, can you tell me one critical thing that you missed? Because you must have read everything now, so you'll probably be knowing what you've missed so far.
Sir, one more important thing that we have to make sure that the patient does not have any pain, and the nociceptive reflex that the patient has also plays a role, and it usually starts when the femtosecond laser starts. So immediately when we do the suction, the patient is not moving the eyes. As soon as the laser starts, they have a nociceptive reflex, and that is the time when we get it. Apart from that, the incidence of suction loss is mostly when the cap cut is being made, because by that time the patient gets anxious and they run out of patience, or they start moving their eyes, or they start searching for the light, which is not visible when the posterior lenticule cut is made. So once the posterior lenticule cut is made, we have to emphasize to the patient that they will no longer be seeing the light. They just have to keep looking straight and not do a searching movement for the light. That is one important thing.
You're very right. In fact, you have touched upon what I wanted you to. But so the most important thing about suction loss is the biggest factor. I mean, beyond all those things that you already mentioned about loose conjunctiva and fluid and all those things, and also patient squeezing the eye and all that, is verbal anesthesia. Okay, so ये nociceptive वाला भी ठीक है, but frankly, in my experience, when we've kind of when we start the laser, I don't see any of my patients actually suddenly make any kind of movements. So they invariably will start making those funny movements when they stop seeing the green fixation light, as you said. Because once the moment your lenticule cut is over and your side cut is over, and as soon as the cap cut starts, because it starts from the center out, right? So
Yes, sir.
that when it starts from the center out, the green light is no longer visible at all, because till the lenticule cut was done, it was still slightly visible to them because it was only a single plane of OBL. Okay?
Yes, sir.
ठीक है
And
ना?
that is why
And the
in
moment your
our
second
settings
plane
also.
of OBL also starts, so second में अब क्या था, when smile was started initially, the second, the cap cut also used to start from the periphery in. Okay?
Yes.
When they first
Okay.
started experimenting with smile.
Oh,
But then
okay,
what
sir.
used to happen was that there used to be a problem with the this thing. उसमें वो आ जाता था. There was a problem which was happening. I'm forgetting what it was, and that used to cause issues with visual results and visual outcomes. So then they changed the pattern, and then they started doing this, that पहले from outside in आएगा, then inside out जाएगा. But in the process, that problem got solved, which was coming with the visual outcomes. But then this problem started that the green fixation light would no longer be visible. So how to ensure that once the green light is not visible, how to how to kind of ensure that patient is not going to become suddenly like lose his fixation, and he might just go into a situation where he starts looking elsewhere. So it's like you have to be talking the patient through, and in fact that is the biggest factor for preventing suction loss in smile patients, that you have your communication and what you're kind of communicating to the patient, and how you're talking them through and walking them through and kind of keeping them busy with thinking and listening to you is what matters the most,
Yes, sir.
because that is the one most important factor beyond what all you've already said. Those are obviously important, but this is another very, very important thing which really makes a huge difference to our incidence. So incidence of suction loss was found to be much lower, if your studies have already been talked about, that where the surgeon was communicating nicely to the patient about how to manage it. I mean,
Yes, sir.
what to expect and how to deal with it. ठीक है, चलो अब आगे
Yes.
चलते हैं.
In fact, sir, in one of the studies, which I have not included in this because it's a generalized smile ka study, Dr. Dan Reinstein has actually given a proper script in which he has said that you have to not talk too much, but not talk too little. And if you stick to the script, it works well in 90% of the cases. So there is a script which he
Right.
has prepared and published it on the paper. You speak all of
Great.
this and it will be all good. So he has actually made out a script also,
So
which
is
has
it
been
very
published.
different from what we normally
No,
do, or is it
no, it
similar
is
to what we do?
exactly the same. It is exactly the same that what you say.
Oh, and I've never seen it actually.
Yes, sir. Yes. So
Okay.
coming to
चलो, ठीक है.
suction loss stages, if the lenticule has been cut, that the posterior plane has been cut less than 10%, we can immediately redock and restart the procedure. If the lenticule progress has occurred for more than 10%, we have no option but to convert to surface ablation or LASIK in the same setting or a later date. But a few papers have also said that if the cap thickness and the corneal thickness has been adequate, and if your original cap thickness was higher, say 125 or 130 microns, then you can still do a re-smile after more than 10% of the lenticule has been cut, but at an anterior node plane. If the suction loss occurs at the lenticule side cut phase, we have to just redock, but we have to change the parameters and we have to repeat from the lenticule side cut. We have to reduce the lenticule diameter by 0.2 to 0.4 mm, and also we have to increase the minimum lenticule thickness by at least 5 to 10 microns to ensure that the entire depth of the lenticule is being cut. So if less than 10% of the lenticule is cut, you redock and restart without changing the parameters. More than 10% of the lenticule, you have three options. You have to do ReSmile at an anterior plane, you have to do surface ablation or LASIK. You can decide based on the patient's cooperation whether or not to do it on the same sitting or a later date. If the lenticule side cut has been aborted, then you redock. You change the lenticule settings by reducing the lenticule diameter by 0.2 to 0.4 mm and also increasing the minimum lenticule thickness by at least 10 microns so that the
Wait a
entire
minute, you come
lenticule
again for this one. What you're telling just now is this one where you increase the lenticle thickness by 5 to 10. Which is that scenario again? Can you tell me again?
if the lenticule has been cut but the lenticule side cuts have not been made.
Okay. Okay. Lenticle side cut is not made. What will you do and where will you start it from?
Sir, we will start from the lenticule side cut phase only, but फिर उसमें lenticule
Okay.
का
But you'll
diameter
decrease the
कम करके
diameter.
by 0.2
ठीक है.
mm and
Tell me why you will
increase.
decrease it. No, I want to understand why all this is being done.
Sir, because we want
How
to
will it
make
help?
sure, because the proper centration of the lenticule again might not be exact because of the OBL and the proper
Yes,
centration
yes.
might not be there. So we are slightly reducing the diameter so that we are still within the lenticule cut and we are increasing the minimum lenticule
Right.
thickness because we are not exactly in the complete periphery. In the complete periphery, our original 15 microns of minimum lenticule thickness would have worked. Now, since we are little bit in the central part by 0.2 to 0.4 mm, we have to increase the minimum lenticule thickness so that it cuts all the way through.
No, why will it help? Because when you're little inside your lenticule thickness will actually be a little more over there.
That's why, sir.
You're
So
removing a
उधर,
convex lenticule, right?
हाँ sir.
So in the
So,
extreme periphery of the lenticule, the
yes,
lenticule might be 10 or 15 microns.
correct.
If you come 0.2 millimeters inside, it might be just about 17 microns instead, which is
इसलिए सर
already enough.
बढ़ाना है. Yes. तो उसी
तो
के लिए
नहीं
बढ़ाना
बढ़
है.
तो वैसे ही गया वो.
नहीं तो फिर वो कट
अच्छा
बनाने के लिए
मतलब
आपको और
कट
10
नहीं
माइक्रोन.
करेगा पूरा उसको,
हाँ
साइड कट नहीं करेगा. व्हाट यू आर सेइंग
हाँ.
इज कि वो
Yes.
साइड कट नहीं करेगा ना.
Yes.
Right. ठीक है. And what is the third thing that you said? Two things. One is decrease the size by 0.2, increase the side cut
Minimum
का thing by
lenticule thickness. Yes.
right. And third आपने तीन चीजें बोली थी ना.
नहीं, first was redock. Second is change the parameters
नहीं
of
वो सब तो
lenticule
ठीक है.
depth.
हाँ.
बस. Then I am coming to cap cut.
Okay, now I also want to ask you that suppose you redock with the same patient interface, huh?
Yes, sir.
And now patient has OBL. How will the patient center again? Because उसको तो green light नहीं दिख रही होगी. And how will you know whether you have kind of come on the same centration as you were
Yes, sir.
before?
So
Because
in
that
that,
also is difficult because as you know that when we dock it, so we try to aim for getting the patient to see the green light and somehow manage to make them, kind of center of the pupil or oblique center of the visual axis. But it's truly not a very perfect science. So how
yes,
will you know that you are at the right place? You are not
yes,
able
sir.
to see the pupil because of the OBL.
नहीं सर, वो इंफ्रारेड का लगा के pupil दिख जाता है ना. And then immediately
Yes.
redock
So you
नहीं
have to
करना. You have
mention
to
this.
let the OBL settle a little bit. You have to first, when the suction is lost, first you will calm down yourself and the patient. You will give him a verbal anesthesia. You will give him separate set of instructions. You will rethink your plan. And by the time you're doing that, 5-10 minutes will elapse, and then the OBL will be slightly settled. So the patient's view also will be slightly better. And with the infrared mode, you are able to see the pupil centration. And like you mentioned, it is not exact
Yes, so
science,
this is
and
the
you will
most
not.
important thing. You have to use the infrared mode because what you are seeing through the microscope may not allow you to see the pupil. So you have to look to the side on the screen where the infrared mode comes, and you will be able to then know that whether you are in the center of the pupil or not. Okay, na? So because in what you are viewing inside the microscope, you may not be able to see the center of the pupil at all.
Okay, sir.
Okay,
Yes.
na?
Yes. So now,
Chalo, let's go ahead.
if
Yes.
we have suction in cap cut, which is the anterior plane, we have to redock, and we need not change the parameters. You have to repeat from the cap cut, and you have to recenter using the infrared light or clear central bubble. If in the cap side cut suction loss occurs, you have to redock, and you have to change the cap diameter by 0.2 to 0.4 mm again, so that we cut actually where we are lenticule is. So studies have shown that it is advisable to clean the contact lens before redocking or change the contact lens completely, and the procedure should be restarted as soon as possible before the reference bubble layer disappears. So what they mean to say is that we need not wait for the entire OBL to disappear, because that OBL itself is going to give us some idea about the margins and the amount of cutting that has occurred. So we need to find a sweet spot wherein we want to calm down the patient, rethink our strategy, have the OBL lessen a little bit, but not clear entirely. The lenticule diameter and the cap diameter may be reduced by 0.2 to 0.4 mm, and the depth of lenticule side cut may be increased during the repeat procedure to compensate for mild decentration during redocking. So one more dilemma which occurs is during, so these guidelines are crisp and clear, and there is no dilemma in this because the machine will not allow you to do anything other than this. The only dilemma which will occur is if you have a suction loss during the lenticule cut, especially when it has progressed more than 10%. That is the time when you have to actually decide, do you want to go for a re-smile, you want to go for a flap, or you want to go for a surface ablation, and that too at the same sitting or a later date. So decision making as such on the spot has to be made only when the posterior lenticule cut has been more than 10%, and then you have a suction loss. So what if we convert it to surface ablation or LASIK? In the same sitting, there is a risk of having increased higher order aberrations and multiple interfaces. If we do a second sitting 4 to 6 weeks later, there is a lesser risk of higher order aberrations. If you decide to repeat smile at a different plane, that is 10 to 20 microns apart, you have a risk of multiple interfaces, irregular interface, and increased higher order aberrations. So from what I gather from Dr. Jeevan Titial sir's talks, in AIIMS RP Center, their preferred method of managing more than 10% lenticule cut suction loss is to convert it to surface ablation or LASIK, and to do it at a second sitting, which is 4 to 6 weeks later with proper topography. So they do a topo guided treatment. So again, redocking in smile in the same
What
sitting.
What is the logic for doing a topo guided treatment?
So because the femto has cut through a few lamellae, so your topography is going to change.
Is there any study which has shown that there is a change in such eyes in topography?
Study, I have read one study, sir. I have not quoted it here, but I will bring it to your notice, sir.
So if there is a study which shows that after doing a deep, see, because the lenticule cut is happening at a very deep plane.
Yes, sir.
Okay. And it's unlikely that any lenticule cut, especially when there is no side cut. Okay. Because there is no side cut till the time that you have completed the lenticule.
Yes, sir.
So if there is no side cut, the chances of any change happening on the topography is like negligible.
Okay, sir. I will do a deep dive into this and get back.
So I don't see any logic in this particular thing that you'll have to do a topo guided treatment.
Sure, sir.
And also whether to do PRK or LASIK in the same sitting versus another sitting. So that you are right that while most surgeons will be tempted to continue on the same sitting because they'll want to convert it to a flap and then try to go ahead with the treatment because the patients may be not amenable to a separate sitting and all that, and the inconvenience of calling the patient again, loss of face and loss of reputation, all those things. So most surgeons would actually want to do a flap on the same sitting. But PRK on the same sitting is definitely not a great idea because we've already played about with the surface, right? So
yes, sir.
when your patient interface has touched the cornea and everything, so there will be surface changes which are not going to be fine unless you're planning to do a brush or alcohol assisted epithelium removal. Then you could still do it, but it may not be a great idea. So yet the best way would be to not do it on the same sitting. You can give a 10-15 days gap and then go and maybe do the flap and then do or PRK as well. Okay.
Okay, sir.
Okay, so let's go on. Yeah.
I have a question.
Yes.
Yeah, so if you want to do it in the same in the second sitting, So I want to know how will you counsel the patient and what treatment would you put the patient on during these 4 to 6 weeks?
So the counseling would be that you have to say that, patient would obviously know that treatment would not be completed because he is probably being uncooperative, right? And
Yes.
you'll tell them that, because your eye was not, properly still and it was moving a lot, we encountered a situation where, machine for the sake of your safety was it tends to abort the treatment and there's nothing which has changed in your eye. Your power remains the same and everything. So we've not lost anything. So first you have to reassure that the treatment was aborted, but it just reset to zero and no kind of correction has been attempted. Your same glasses are going to work for you. So usually patients are okay with that, and then you'll tell them that during this time you'll put them on a lubricant and maybe a mild antibiotic steroid for the sake of whatever little inflammation was created by the small cuts that you created, and
Okay.
you will come back after 2 weeks and then go ahead with whatever you plan to do subsequently.
Okay. Okay. Thank you, sir.
So redocking
Pranav,
in
also here I wanted to ask you
yes.
that did you find the video of our patient where before you guys joined, we had a patient where we had a suction loss during lenticule cut and where we went with a smile again.
Uh, no, sir, I have not come across a video of Resmile, but I do have videos of, Resmile at an
So you
anterior
find that
setting.
patient, you ask Pramod, he will tell you because we did one patient say about 6 months to a year back where we had a suction loss. Then we changed the parameters to a thinner cap, a much thinner cap and also a much thinner lenticule by decreasing the optical zone. And we went with smile again.
Okay, sir, I'll find it out, sir.
Yeah, if you talk to Pramod, he will remember and he will be able to find it for you, and then you can prepare this as a kind of a case presentation or something on
Yes,
what
sir.
to do when this kind of a thing happens because it's an atypical situation, as you said.
Yes, sir.
Okay, let's go on.
So what are the challenges and what are the advantages of redocking in Smile in the same setting? So immediate redocking, the bubble layer is going to guide you to your previous centration. It is especially significant in larger mesopic pupil size because the pupil center is unstable and it shifts with the pupil size under different lighting settings. Also, the bubble layer may adversely affect the laser energy delivery and the surgical accuracy, and you might have a surgical undercorrection of up to 2 diopters. So, what if you delay repeat procedure for 1 to 2 hours after initial suction loss? So, you can ensure that the disappearance of the gas bubbles and the corneal edema and then recenter, and possibly you can have a better centration during the repeat procedure. So, these are just theories put forth by various surgeons. So, essentially, management of suction loss in Smile depends on the stage at which the suction is lost. To repeat, less than 10% lenticule cut, you redock and restart the procedure and recenter using the infrared light or clear central bubble. More than 10% lenticule cut, you convert to surface ablation, LASIK, or resmile at a anterior part. In the lenticule side cut, you are going to redock, change the lenticule reduce the lenticule diameter by 0.2 to 0.4 mm, and increase the minimum lenticule thickness by 10 to 20 microns. During the cap cut, you have to redock and repeat from the cap cut without any change in the cap parameters. During the cap side cut, you have to redock, change the cap diameter by 0.2 to 0.4 mm, and do the incision. So it is said that if suction loss occurs when more than 10% of the posterior surface of the lenticule is created, an immediate femtosecond laser pass on the posterior surface of the lenticule may cause an irregular lenticular surface and cause multiple lenticules leading to free slivers of the corneal stroma. So the main debate which occurs is more than 10% of lenticule cut. Sir, one thing to note is that our class timing will end in a couple of minutes. So I'm going to be sending a new link on the group. So if this class ends, we can join in that link.
Sure.
Sir, I've sent the link on the group, sir.
Okay.
So after this, I'm going to be discussing the literature and what. Now coming to the review of literature, in a study which they have studied the clinical outcomes of immediate reapplication of SMILE without adjusting the surgical parameters after suction loss. So they say that when the suction loss occurred during the posterior lenticule surface cut, the SMILE procedure was repeated from the beginning and the surgical parameters were re-entered without modification in their study. In their study, when the suction loss occurred during or after the cap was cut, the SMILE procedure was repeated from the point at which it was stopped. So in these cases, they found that the surgical parameters did not need to be re-entered into the laser control platform. They have found that the suction loss occurred in 53% of the eyes during the posterior surface cut and 47% during the cap cut, which is contrary to the overwhelming evidence shown by other papers in which most of the cases occur during the cap cut. So what were the visual outcomes, efficacy and safety, and what was the limitation of their study that I'm going to discuss. So in 99% of the eyes in the suction loss group and the 97% of the eyes in the uneventful group showed a post-operative 6-month uncorrected visual acuity of better than 20/20, and the mean efficiency index and the safety index did not significantly differ between the two groups. So they mean to say that the visual outcomes were very good in the suction loss group as well. What about the refraction, predictability, and the keratometry? The mean sphere, cylinder, and spherical equivalent values at the 6 months post-op did not differ significantly between the two groups, and the average post-op K values and the corneal toricity did not significantly differ between the two groups. What about the aberrations? So the changes in corneal higher order aberrations, including the total higher order aberrations, spherical aberrations, and horizontal and vertical coma, did not significantly differ between the two groups. So the results of this study suggest that it is possible to achieve clinically safe and effective outcomes by immediate reapplication of the SMILE procedure after suction loss, even if the posterior lenticule surface cut has been progressed by more than 10%. This, they have said, that can be attributed to a high level of accuracy and reproducibility of the newer generation femtosecond laser platforms. In addition to this, the treatment centration during immediate repetition of SMILE procedure was based on the triple centration markings which they do for their all the patients, and their original treatment plan included the centration markings. Therefore, the treatment centration could be accurate even in the suction loss group. So they did not see any surgical complications like double interface layer or torn lenticule. They did not see any intraoperative complications like during lenticule dissection and extraction issues in the suction loss group. However, in this study, the limitation is that they have not classified their posterior lenticule cut suction loss based on the percentage of percentage of completion. So what they have done is they have grouped all of them, be it less than 10% posterior lenticule cut or more than 10% lenticule cut, and they have not published the data also that how many patients had more than 10% of lenticule cut already done and then they have done ReSmile. So these results we have to take with a pinch of salt.
Wait a minute, Pranav. I thought they were talking only about those where it was more than 10%.
No,
Go back
sir.
one slide. Okay, let's go to the next slide.
So their posterior lenticule surface cut, in the blue ones I have written the first point. They have said that they have combined the data of less than 10% and more than 10%. So we have no way of finding out more than 10% wale aadmi ka kya hua. That is the limitation of their study. And they have not mentioned
for
also.
The person who's performing this procedure, what will be the difference between less than 10% and more than 10% in what you do? What will you have to do when you want to kind of do SMILE again with the same parameters and your cut was more than 10%? How will you approach that situation? Theoretically speaking, if we decided that you still want to go with SMILE of the same parameters, what will be different that you'll have to do?
Sir, probably reduction of the optical zone. If I mean, if you are
No, but they're
going
saying you
to,
did not. They are saying you don't have to change the
yes,
parameters at all, right?
yes, sir,
Well,
yes,
let's
sir, they
assume
did.
that we are not changing the parameters at all. So what will you do now? You have had a suction loss. You had more than 10%. Your machine is saying that you can't proceed now with the smile, and you have to now proceed with a flap, or to just decide not to do anything.
Yes, sir.
What will you tell the machine?
Sir, then we will, I am
It
not
is not
sure,
giving
sir.
you an option to do smile again.
I don't know, sir.
Shruti or Amrita, anything?
No, sir.
Nahin? Okay, so see, I know because it's something which is not given in any book now. So obviously you will not know, and frankly, I have not done it either, but I know what can be done. If you really theoretically wanted to do this, you would have to feed another new treatment with the same parameters. You can't proceed with that same treatment because it's now aborted. You'll have to say, okay, we don't want to do anything. And the machine will say, okay, you abort the treatment, and there it is. Then you program the treatment all over again with exactly the same settings as what you had for that particular treatment. And ideally, you will use the same patient interface also as you were already using. जो वहाँ पे वो cone लगा हुआ है ना, you will not reuse that cone. I mean, you will not put a new cone because each cone is calibrated to produce a different depth, to some extent. So you can use the same cone and then go with it. But frankly, I've never done it, and I don't know whether it's the right thing to do, even though this study seems to be saying that. So that's what I wanted to just tell you. So let's go ahead.
Okay, sir. So another study comparing the impact of suction loss during small incision lenticule extraction. So in their results, the high contrast corrected distance visual acuity was significantly worse in the eyes that experienced suction loss at only 1 week. But there was no significant difference at 1 month and 3 months. But in this study, they have mentioned about corrected distance visual acuity and not uncorrected visual acuity. Second thing, they have noted that there was no statistically significant difference at 3 months in the higher order aberrations. One more thing they have mentioned in the study is about the three-dimensional OCT images that they have done. They have noted that there was a hyper-reflective line which was clearly seen at the surgical interface at 1 day after the surgery. However, this hyper-reflective line was clearer in 6 eyes that received the femtolasic retreatment after suction loss than in contralateral eyes. And this hyper-reflective line disappeared at 3 months post-operatively. And they have noted that there were no differences found between the eyes retreated with smile and contralateral eyes treated with smile. And this hyper-reflective line disappeared at 1 month post-operatively in all eyes. So again, this paper is also giving us half the information. Another paper showing the risk factors and the incidence of suction loss during small incision lenticule extraction in over 8,000 eyes. So they had classified the kind of eye movements and the head movements that they get and the stages at which they get. So the head movements they have classified as raising the chin, lowering the chin, and slight deviation of the head position. So if we were to see significantly in their study, half of their patients had a suction loss because of head movement and half of their patients had suction loss because of eye movement. So head movement is also an essential factor to consider, not only eye movement. So we have to tell the patient to keep their head also steady apart from their eyes. So for eye movement, they have classified it as Bell's reflex, light tracking, and eye rotation. So they had 31 cases of suction loss overall in about 8,000 eyes. So in which stage
So
did
let's
they?
also see the bottom chart. Let's see the
Yes.
bottom chart also, what it's trying to tell us.
So they have classified according to the stage of suction loss. Resoundingly, most of their cases have occurred in the cap stage. 60% in the cap interface and last 25% in the side cut. So only around 12 to 15% of their suction loss occurred during the lenticule stage.
But surprisingly, they have almost 25% at the stage of the small incision, which
Yes,
is
sir.
very unusual.
Yes, sir.
Most often, I mean, it's during the cap cut. So small incision is so fast that it's very, very rare to get it. Chalo, theek hai.
Yes, sir. In their study using logistical regression, they have found out that first operative eye and male sex were at a significant higher risk of developing suction loss. So their logic for higher incidence during the cap cut was that the air bubbles generated from the lenticule cutting obscure the patient's vision and the patient loses sight of the green fixation light. The patient panics and hence the eye movement or the head movement. In their study, they have told about the drawbacks of immediate continuance using a redocking technique. So what are the disadvantages of redocking? They have said that there is increased patient anxiety, difficulties in observing the pupil center due to presence of the air bubbles, risk of treatment decentration due to difficulties in pinpointing, risks of uneven lamellar cuts, and increased anxiety of the surgeon as well. Hence, they have said that the correct position of the body and head is crucial. So in addition to adjusting the headrest, soft pads may be placed under the patient's head when necessary, which we do regularly. So this is one thing which we do. Despite giving the patient a headrest, we are still putting surgical drapes under the patient's head to make it more comfortable and to make it more level. So in general, we must maintain the patient's head at a horizontal level, which will help the patient to remain still during the surgery and to refrain from raising or lowering their chin. So in their study, what were the intraoperative risk factors or the treatment planning risk factors that they found for higher incidence of suction loss? So they found that larger cap diameter and higher cylinder might be related to a weaker grasp on the cornea by the suction cone or to a lower shape compatibility between the cornea and cone. So larger cap diameter and higher cylinder have a slightly higher risk of having suction loss. Similarly, smaller palpebral fissure, steeper corneas, smaller corneal diameter, and conjunctival chemosis. So they have noted large cap diameter, higher cylinder, smaller palpebral fissure, steep corneas, smaller corneal diameter, and conjunctival chemosis as risk factors, ocular risk factors for having a suction loss. They have also found that the central corneal thickness, the residual stromal bed, cap thickness, and the size of the optical zone were not identified as important risk factors for suction loss.
So here, optical zone,
Yes, sir.
right? So is there any study which is comparing the incidence of suction loss between a 6 mm zone and a 6.5 zone?
Sir, I have not come across such study in my literature.
It will be worth seeing because see, when you go from 6 to 6.5 optical zone, your duration of treatment goes up by almost 5 seconds.
Yes, sir.
Theoretically speaking, that should be a cause for more incidence of suction loss as we also understand when we treat ourselves.
Yes, sir. Yes, sir.
Because the longer the treatment, the more chance that you will have a suction loss because the patient starts losing patience.
Yes, sir.
So it'll be
I'm not-
worth checking if this has been a factor, although they are claiming it is not.
Yes, sir. I'll recheck, sir, the literature. Also, sir, the literature review is heavily limited by the kind of papers I'm able to access freely because Journal of Refractive Surgery usually unke papers jo hote hain, so they are not accessible on Sci-Hub and we don't have a subscription also. So we are not able to access the papers. Matlab abstract I am able to
So-
read, but it does not give us a deep dive into the papers.
So जो papers आपको नहीं मिल रहे हैं ना, we should take help. Like for example, institutional वाले जो लोग होते हैं, उनको अगर आप बोलोगे, so they will usually kind of help you out by giving you those full text of those papers. So you could obviously send them to Abhijay or Anshika if they can access, or you could send it to some of your colleagues who are at SN or some other institution. They will usually, for them, it's a straightforward thing to get those full
Yes,
text
sir.
papers.
Sir, I
Or you can even
actually
put it on a group where you are, where like for young ophthalmologists वाला कोई group होगा जिसमें somebody is in an institution. If you just put it there that I would request somebody to give me the full text, you'll get it very fast.
Yes, sir. Actually, I've tried for Journal of Refractive Surgery in SN. SN had a subscription only up to 2013, so they are able to access all papers up to 2013. But after that, last 10, 11
अच्छा,
years के उनके पास नहीं है, तो फिर भी latest papers का problem हो जाता है. But I'll still
okay,
find a way around it.
sure.
Coming to the next paper, which studied the suction stability management in small incision lenticule extraction. They have studied the incidence and outcomes of suction loss in 4,000 consecutive procedures. So in their protocol, the treatment was continued as SMILE where possible, including reprogramming with a reduced cap thickness if the suction loss occurred during the lenticule interface. So this option was only used if the initial cap thickness was 135 microns or more, and the reprogrammed cap thickness was at least 25 microns thinner. That is, it was at least 110 microns. The logic behind this is that the reproducibility of the cap thickness has been reported to be around 4.4 microns. That is a standard deviation of plus minus 5 microns. So if we are planning to make a cap thickness of say 135 microns, it can be anywhere from 130 to 140. That is what they mean. So this protocol allowed for more than 5 standard deviations between the initial and reprogrammed cap thickness, hence minimizing the risk of crossing into the original aborted lenticule interface. So in this study, Dr. Reinstein et al. Has classified the causes for eye movement. The first one being Bell's reflex, which we know. The second is fixation light tracking, which is a gradual, low-speed, constant direction movement in any direction where the surgeon was instructing the patient not to follow the green light. Patient anxiety, which gives rise to random and uncontrollable eye movements. Or nociceptive reflex, which occurs almost immediately after the initiation of femtosecond cutting, and false suction, which was identified in cases where the conjunctival intrusion was seen within the contact glass. So in their study of SMILE retreatment, they found that there was no difference in visual and refractive outcomes at 12 months between the suction loss group and the fellow eye SMILE group, which indicated that the results were unaffected by the suction loss. One thing to note here also was that there was no difference with respect to safety, as only one suction eye lost one line of corrected visual acuity, and there was no change in contrast sensitivity. So despite whatever mode of treatment they chose for retreatment, be it ReSmile or Surface or LASIK, their outcomes were still good. So one more important point that they have put forth is about the need for sedation during SMILE surgery. So in their study, they have said that eye movements during surgery are more common with anxious patients, which can be used as an argument for sedation in all patients. However, laser refractive surgery is best performed with a patient who is awake and alert so that they can respond to a surgeon's instructions, and sedatives can lead to less cooperative patient. Also, they have noted that an oculocardiac reflex occurs more frequently in sedated patients, which may influence the suction stability. Therefore, Dr. Reinstein et al.'s protocol for sedation is that they only prescribe a sedative before surgery in rare cases, which is only 1% of their cases of patients with an actual anxiety disorder, such as patients who have panic attacks or those who suffer from claustrophobia. So that is their logic.
What is our experience?
Sir, our experience is that honestly, in the 4 months that I have been here, I find that especially in small, lean, thin females, even that 0.25 mg of alprazolam makes them extremely, extremely sleepy. And I have not noticed it, especially during SMILE. But when we go to the other center and see them for their topo scans, or when we are, doing their femto cuts, and when they are sitting outside for their examer part, they are extremely, extremely drowsy and sleepy in thin females. In healthy male, I
Yes.
mean, हेल्दी मेल्स में नहीं देखा है मैंने, बट लड़कियों को तो प्रॉब्लम होता ही होता है.
Yeah, even I have experienced the same. Thin, lean females, they are drowsy by the time the actual treatment.
That's probably also to do with that it happens very late in the evening. By the time they're exhausted.
Yes, sir.
So do you think we should discontinue doing that for some of these, for the young, like that group which you're describing?
Sir, we can, but also I would like to highlight most of the females are also very anxious. So for the treatment. So if we don't give them, then that will also be a problem because we won't be able to judge the amount of anxiety, and most of them won't reveal also whether they are anxious or not, or whether they are having any panic disorders or anything. Not every patient will be honest, so it will be really difficult to judge.
True. So I think it's a gray area. Okay, let's go on.
So
One should
the
also be aware of the incidence of vasovagal in young females, like the group which you described, that one has to be very careful. So I'm very usually careful that the moment they are asked to get up from the bed, you should not make them stand up immediately. Let them sit for a
Right.
moment on the bed and move their feet a little bit and then ask them to stand up. Some of them will just kind of, the moment they stand up, they'll have a vasovagal. It used to
Yes,
happen
right.
quite often at our LASIK center before. And now we see less of it because during SMILE, actually, there is no discomfort. Whereas during microkeratome LASIK, we used to have significant discomfort, especially the machine may used to make a sound of a motor running, and they used to think that a blade is cutting my eye and all that. So they used to be terrified. And then, we would notice, and they would be visibly anxious during the surgery until the end of surgery. And then we would have an occasional patient have a vasovagal just after they got up from the bed. We see it much less now because most of our treatments, at least in SMILE, it's very, very rare because actually there is no discomfort during the procedure, which patients should be very uncomfortable about.
okay, so
Let's go ahead.
yes, sir. So in a vast majority of their cases, Dr. Reinstein et al. Has noted that in 54% of the cases of suction loss, there was noted of fluid entry through the suction ports. So that is something we have to keep in mind. As soon as we start seeing any fluid creeping in through the suction ports, we have to be aware that there can be a potential suction loss, and to be aware with our foot pedal, at any point we might have to take our foot off the pedal. And one more interesting thing that they have pointed out in their study is that the most likely reason for higher incidence of suction loss in their patients was the use of closer spot spacing of 3 microns for the lamellar interfaces and 2 microns for the side cuts. Reducing the spot spacing increases the total treatment time, thus increasing the risk of suction loss. So one question I had here, sir, was that we are using the expert mode in which we are able to program the spot spacing. So I'm yet to actually go and see in our machine what exactly our spot spacing is.
I think you now have an answer to what I was telling you, the optical zone bit. By increasing the treatment time, for example, by increasing even the optical zone, you are increasing the treatment time, right?
Yes, sir. Yes, sir.
And that is basically the same thing what they're trying to say for a different reason by having spots separation is much smaller. Again, they are basically saying that when you increase the treatment time, the risk of suction loss goes up.
Yes, sir. So another study studied the clinical outcomes of immediate transepithelial PRK after suction loss during SMILE. And they have in all the included eyes, the suction loss occurred during creation of the posterior lenticule. So in their study, in total 11, that is, and 12 eyes of the transepithelial PRK and uneventful SMILE groups, this is a contralateral eye study, showed a 6-month uncorrected visual acuity of 20/20 or better. So even the suction loss eye, which was treated with trans PRK, had a good visual outcome. They say that the mean absolute spherical equivalent values at the 6 months post-op were not significantly different between the two groups, but they have noted that the mean absolute cylinder value was much smaller in an uneventful SMILE group than the transepithelial PRK group. They say that although the transepithelial PRK group showed a significant increase in the spherical aberrations at 6 months postoperatively, the uneventful SMILE group showed no significant change. So they have noted that in posterior lenticule cut, if you have suction loss and you're retreating with trans PRK in the same sitting, they have noted that the cylindrical error was more than the uneventful SMILE group. The post-operative cylindrical error was higher in the trans-PRK group, probably because the eyes in this group consecutively had two different types of corneal surgeries, which may have induced an additional corneal wound healing process that could be associated with the slightly higher post-operative cylindrical error. The remaining post-operative cylindrical error could also be associated with the lower post-operative visual acuity in the transepithelial group. So, sir, like you mentioned in this class before, they have done a trans PRK and not an alcohol or a brush PRK. And when you are doing a trans PRK in an eye which has already undergone suction, and that too they have done immediate trans PRK, you are bound to have some error, and they have said that they got an error in the cylindrical correction. So what you said makes sense in this study as well. Sir?
Okay, I was trying to say something. I was saying that, if you had to do this thing, I would do a brush assisted PRK because the lenticule cut would be at least, if not less, 180 to 190 microns deep. Okay. Because you'll have a 120 cap or 130 cap, and then you'll have another 50-60 microns of lenticule. So your cut would be at least like 200 microns deep, right? So even if you go with PRK to any depth, you're not likely to ablate more than 50, 60, 70 microns. That's usually the limit to which you'll go. So including the epithelium, if you were to do, you would probably not be going deeper than a total of 120 or 130 microns. So you're not going to come anywhere close to the lenticule cut. And that part remains untouched mostly. So I think a PRK would, a brush assisted PRK would still give good results if you had to do it.
Yes.
I'll tell you one more thing.
Yes.
Pranav, you could do this. We could do one thing that, when we do smile for a patient, or frankly, let's do one study that when we cut flaps on the Visumax, okay?
Yes. Yes.
We don't do smile, but we just do a flap. There we are not really doing any major interference to the ocular surface except the contact of the glass, right?
Yes, sir.
We are not going for any dissections and everything. We are not changing the curvatures. So it's almost like having a eye which had a suction loss after the, aborted lenticule cut. Okay.
Yes.
So what we can do is we can do a epithelium study to compare pre and post Visumax flap to see what changes happen to the epithelium by the suction.
Yes, sir. We can do that.
That might tell us whether, trans PRK will remain an option or not. If it shows gross abnormality of the epithelium in that central area, which matters, then we'll know that, trans PRK is not a great idea for such patients.
Yes. And it is convenient also क्योंकि anterior side में ही है उसी room में. So anterior.
Exactly. So when they come out, we just do an anterior and we do the. And we give 5 minutes before we actually do the test. Like after you've done the flap cut, you let them sit for 5 minutes outside. And then after that, we just do the scan after their ocular surface is stabilized, 5
Yes,
to
sir.
10 minutes.
Yes, sir. Yes. I will do
Okay.
this next. Yes.
Sure.
So coming to another study in which they have studied the refraction outcomes after suction loss during SMILE. So they divided the patients in two groups. The first group was without suction loss. The second group was with suction loss. So in group A, they have said that it was possible to complete the surgical procedure by redocking and completing the technique. And in group B, the procedure was postponed for 24 hours and the same procedure was repeated. This showed that the group B, which was the suction loss group, this study has showed that there was a hyperopic shift in the group A compared with group B at the post-operative 6-month follow-up time. So they say that this can be explained as creating a second pass immediately after suction loss might result in an uneven lamellar cut, an irregular interface, and creation of two different dissection planes and more tissue squeezed within the regained suction due to differences in applanation pressures, which might result in more tissue cutting and extraction and hyperopic shift post-operatively. However, with the repetition of the procedure after 24 hours, there is enough time for the fluid and gas created to be absorbed before treatment. So one correction I would like to make, Group A was immediately, Group A and Group B are both suction loss groups. Group A was immediately retreated and Group B was 24 hours late. So they have shown that immediate retreatment showed a hyperopic shift because of the said reasons. Coming to one more study which compared the immediate smile after suction loss with uneventful smile. They said that the main drawbacks to immediate smile using a redocking technique after suction loss include patient anxiety, difficulties in centration of the lenticule because of the lack of visibility of the pupil because of the presence of the bubble layer, and hence the risk of treatment decentration, the risk for an uneven lamellar cut, which can induce significant lower and higher order aberrations, and difficulty in achieving adequate suction because of conjunctival bogginess and the risk of recurrent suction. So in their study, when there was a suction loss during the posterior surface cut, that is the posterior lenticule cut, they changed the treatment pack and the laser parameters were adjusted so that the refractive lenticule was located more anteriorly, that is a cap thickness of 120 to 100 microns. If suction loss recurred during the lenticule side cut treatment, the pack was not changed. However, the laser parameters were changed so that the diameter of the lenticule was slightly reduced. If the suction loss occurred during the anterior, that is the cap, and the incision cuts, there were no changes in the pack or the laser parameters. So in their results, what they have found is that the mean uncorrected and corrected visual acuity was significantly lower. The mean manifest refraction defocus equivalent was significantly larger, and the mean error of treatment was much larger for the suction loss group as compared to the uneventful group. Moreover, 2 eyes of 23 eyes, that is 9 up to 10% of the eyes in the study group, showed undercorrection of more than 2 diopters, suggesting that immediate small incision lenticule extraction using redocking after suction loss was less predictable than uneventful smile. So what were the reasons that they put forth? The second femtosecond laser pass could result in an uneven lamellar cut. In addition, refractive lenticule thickness might be affected by the gas bubble expansion between suction loss and second suction fixation. So previous experimental data has also proved that a second pass of the femtosecond laser might result in 2 parallel cut lines despite waiting for an OBL to clear. And the bubble expansion may lift a refractive lenticule more anteriorly, resulting in undercorrection. So that is what their study has shown. This is my last slide, second last slide. I've come across one very interesting case report wherein they have done a smile, they had a suction loss, and they have done a re-smile, and in that re-smile eye, they had refractive error, which was residual. So for that residual refractive error, they have used Circle software to create a flap and done a topoLASIK enhancement. So we'll go through the pentacam images. The first one on the left is the pre-op images. The patient has a nice symmetric bow tie. The second image shows the smile, re-smile. After the re-smile, what they have done is there is significant flattening in areas which are not central. So in the central area, the cornea was still steep and the patient still had a residual refractive error. So what they did is they did a Circle software, they made a flap, and they did a topoLASIK only in the central area, which we can see very well on the third scan. So they had a complete, they had a suction loss during the cap scan. So during the cap, they had a suction loss. They reduced the cap thickness and they did a re-smile. And when they extracted the lenticule, they realized that a very small tiny bit of lenticule was still stuck to the undersurface, which was causing the refractive surprise in their patient. And hence to retreat that, they have done a third procedure.
So Pranav, why did they do a re-smile? They only repeated the cap cut, right?
Yes, they repeated the cap cut, but at a lesser cap thickness.
Why would they do that?
नहीं पता sir.
Is that recommended?
No sir.
So they already did the wrong thing.
Yes sir.
What
And
I can
they have,
understand is they should have done the same cap thickness,
yes. And इसलिए sir
because if you're
उनके,
changing the cap thickness, you are changing the refractive outcome as well, because you've already got the lenticule cut in place. So if you're changing the cap thickness, then your lenticule thickness will change.
yes sir.
So the refractive outcome will change also. Plus, because it already the cap was cut at till one point, and now you are cutting the cap in with a thinner thing, the risk of leaving behind that small thing in the center increases anyway,
Yes.
because you have two planes.
Yes.
So it's a very unusual thing that they've done, and obviously they got a bad result.
Yes sir. So that's why I included this, because that was something out of the
So
ordinary.
have they given any logic on why they changed the cap thickness?
नहीं sir, actually ये poster type है, मतलब this is not a case report also. This is a poster somebody has presented in some conference.
Okay.
Yes.
Also, if you
So,
can go back 2 slides,
yes sir.
one more. Okay. Here. So no, the other one. Okay, no, the previous one. No, just move one slide. Go ahead one slide. Yeah. No. Go back one slide. Go back another slide. Okay. So point number 2.
Yes.
If suction loss occurred during the lenticule side cut treatment. Okay, so recurred or occurred?
Occurred, sir. Occurred. Yes.
Okay, occurred. That's okay. Occurred during the lenticule side cut treatment. The pack was not changed, which is fine. That's what they no. The pack was not changed. However, the laser parameters were changed so that the diameter of the refractive lenticule was reduced. All this is fine, but the machine at this point does not allow you to proceed with the treatment of SMILE at all when you have a suction loss during the lenticule side cut. Okay, it has happened to me once when my whole lenticule cut was over, but I was doing the side cut and the treatment there was a suction loss. Now I wanted to actually proceed with the SMILE treatment because I thought that it should happen, but the machine had no option of proceeding with the SMILE treatment. It wanted me to go ahead with a cap, with a flap. So I'm wondering that it's okay not to change the pack, but how will they proceed with the treatment by decreasing from 6 to 5.8? They can't proceed with the same treatment line. Okay. And if you program a new treatment, it won't start from lenticule side cut. It'll either start from the whole treatment will happen, or it'll start only from the cap cut, not from the lenticule side cut, according to my understanding.
Yes, sir. Yes.
So can you explain this?
ये पॉइंट ना आपने मुझे हमने एक बार डिस्कस भी किया था, और मैंने आपको एक एल्गोरिथम भी दिखाया था, which I am resharing right now. Yes. So in this lenticule side cut वाला जो था, उस टाइम पे आपने ये बोला था कि I have never seen this thing. तो मे बी आई थिंक सर सॉफ्टवेयर अपडेट के बाद ये होता होगा अभी ऑप्शन, क्योंकि फर्स्ट टाइम also when we discussed this, we
Possibly,
had
because
mentioned the
when
same
this case
point.
happened to me, and this happened towards the early part of our SMILE, this thing. It happened. Okay, so I think we should check this out. We'll talk to this guy called Ekansh. Okay. He will be able to tell because he's the guy who has been guiding us. He's the clinical applications guy. Ask him that previously when we had once, the machine did not give us the option to do a second, continue with the procedure, but now apparently it's possible. So was it so that previously it was not possible and now it's happened? So he will tell you. Okay.
Yes, sir.
So now we are on to the last slide.
Yes, sir. All latest papers are showing this algorithm only for lenticule side cut.
Right. So I think it's good for us. It's probably good for us.
Yes, sir. So my last slide was just a summary and my takeaway points, which are preoperative counseling, verbal anesthesia, clear and easy to understand intraoperative instructions, proper head position, eye position, and conjunctival drying. If suction loss occurs, be calm. All is not lost, because as we have seen through the studies, Most of the cases do still well. You have to rethink the strategy according to the stage of suction loss, patient cooperation, type of the refractive error, and cap thickness. Retreatment results are good in most cases, but they are not excellent in all cases. You have to reassure the patient along each step, and the retreatment after re-smile is also possible given adequate corneal thickness. So these are my takeaway points.
Very good. One more takeaway point can be that go for a new machine which takes half the time.
And double the money, sir.
Obviously. Yeah, but you can't charge the patient double the money. That's the problem.
Yes.
So anyway, these are, yeah. So going for a faster machine might be a good option here, which obviously, can only happen in a center which has very high volumes, which can justify that, right?
Yes, sir.
Okay, wonderful. Anybody else has anything to say to add to this?
Sir, if I may, I wanted to ask Dr. Amrita ma'am to share her experience when she was learning to do smile. कि beginners के लिए कुछ tips like what we have to keep in mind when we eventually start learning.
This is more of a question for sir, I think, rather than me.
Ma'am, but sir,
Okay,
sir
so I think I
is
already
already
contributed
experienced
much
manner.
of the things. When I learned Smile, I went through the whole process which you have already outlined. That's exactly that's my learning curve too. What we've already discussed at length. I learned it the hard way because there was nobody to tell us all this. We had to learn all these things by, like hit and try. What do you call it?
Trial and error.
That method of
Trial and error.
trial and
Trial and error.
yeah. So it was kind of something uncharted territory basically, because when I started doing Smile 8 years back, there were very few people doing Smile and very few people to ask what to do next. So we used to rely more upon our own judgment and try to make decisions and ask the clinical application guy and maybe one or two friends who were doing it. All the same, I think we've learned a lot over the years. So all these points which you discussed today are all what we actually learned, and it's nice. So what I also feel is that in the learning curve, I think for suction loss, what I was telling you in the last OT is that when we should probably learn by just making flaps. So nobody should start Smile straight away on the Visumax at least. One should always start with flaps. Once you are comfortable making flaps in 30, 40, 50 patients, then you know how this machine works and the whole nitty-gritty. Then you are fit to go with the Smile, because then you know that the initial lenticle cut will be smooth and you are already aware of all that. And then you only have to learn the cap cut wala part. So it becomes much easier to transition to Smile. That's my thought.
Mm.
Because with the flap, you are seeing the green fixation light almost till the end, and the treatment time is much smaller. That's just about 10 to 12 seconds, or maybe 13, 14 seconds. So the chances of suction loss are very small. Maybe you should also look up, Pranav, that comparison of suction loss, and Shruti can also see comparison of incidence of suction loss on the Visumax between flap and Smile.
Okay.
If anybody has done that,
Yes.
there should be a vast difference between the two.
Yes, sir. I faintly remember
Also, we
one of
should.
these papers which I've included. They have mentioned it somewhere that they use the same 500 kilohertz Visumax 500 for the flaps as well as Smile, and they have noted that their flap suction loss rate is very less. But I will give you verbatim what they have said. I will quote that also. I have read it in one of the papers. but I didn't
Also,
include-
we should look for any studies now, maybe if not now, then few months later, about incidence of suction loss with the other lenticle platforms. Like they claim that Silk, there is almost no suction loss. Okay, they claim, but we can't be sure. So, in fact, to the extent that Silk has not even got a nomogram like Circle software or a retreatment software as Visumax does. So they say we don't need it because we don't get suction loss, which is highly unlikely because Intralace was also still getting suction loss occasionally, even though the suction is much stronger on the Elita, and also it's not a corneal suction, so patient cannot see anything, so cannot fix it. Whereas on Visumax, the suction is much milder and smaller, and also it's only a corneal suction, right? So there's a big difference between the suction on the various machines, and we should also study that to understand better.
Yes, sir. So one more thing I came across while doing the literature review was that I noted that in the US market, they don't have an option for the circle software. So for them,
Sorry?
in the US market, in America,
Hmm.
they are not having the circle software because I came
Yeah, so
across a
probably it's
couple of
not US FDA
videos.
approved.
I came across a couple of videos wherein, you know, they actually had to do a lot of programming to make a flap out of the suction loss patient and then do the treatment rather than just directly going for circle. And they have made a couple of videos about it for their technique because they don't have circle software in the US.
Right. So that's why probably in the US, Smile is still not popular because there's so many limitations. They can't treat pure cylinders. They cannot treat astigmatism more than maybe 1 or 2 diopters, or they cannot treat astigmatism at all. See, when original FDA approvals came for Smile, they did not have an option to treat astigmatism. That's what I remember. Maybe now they have it. So we should find out what are the current FDA approvals for Smile in the US.
Yes, sir. Yes.
And that's why it is not popular in the US.
Yes.
Chalo, theek hai. And ours is the only platform right now which is FDA approved, which is the Visumax. I don't think any of the other lenticle platforms are still FDA approved.
Sir, in fact, Silka FDA trial is going to end in February 2026. I checked the clinical FDA trial ka website. So it is FDA approved
हाँ,
only to make femtoflaps. In February 2026,
exactly.
their trial is going to end. मतलब उसके बाद उनको approval
हाँ,
मिलेगा.
approvals may still take a lot of time to come. So this can be highlighted to patients when we counsel them.
Yes.
ठीक है जी. So I think we've had a good class, and
Yes.
we can meet again in a couple of days. But a lot of homework from today. Can you note down the homework and post it on the group tonight itself? That what all we kind of decided to pursue further from this class.
Yes. 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 Yes.
चलो ठीक है जी. Thank you. And Shruti, you will get a call for your dental appointment from Dr. Saurabh today. But he's trying to get you something for tomorrow. Okay?
Okay, sir. Thank you so much, sir.
Great. You're welcome. Okay. Bye-bye.
Thank you, sir. Thank you.
Very good night.
Good night. Thanks, Dr. Amrita. Thank you. Bye.
Thanks, Arnav. Thanks, sir.
Bye.